Chapter 16, Pregnancy at Risk, Conditions that will complicate your pregnancy. More women are entering into pregnancy with chronic medical conditions, and there's several reasons for that. We're just not as healthy as we once were, and two, a lot of women are waiting a little bit to have children. They're waiting till they're older, whether it's getting their job established first and entering into pregnancy at a later age. Whatever it is, it's more women are having chronic medical conditions because of these things. As the LVN, you will assist the RN to provide care for the pregnant woman at risk. Okay, so as an LPN, you have to know your scope of practice, what you can and cannot do, and the best place for that is going to be the Board of Nursing. So you can click on that link and go and read up on your scope of practice. All right, risk factors for the pregnant woman. Chronic medical conditions put her at high risk, as well as acute infections, and those are two things we're going to talk about in this PowerPoint. There's several ways in which a pregnancy and medical conditions are interrelated. Sometimes the normal physiological changes of pregnancy will alleviate some of these symptoms of pregnancies, and then other times it will intensify the symptoms of pregnancy, will intensify those diseases. Medical conditions can affect the progress and the outcome of the pregnancy. That's why we're concerned about them, and we're going to look into them. All right, diabetes mellitus. It is a chronic disease in which glucose metabolism is impaired by the lack of insulin in the body or by ineffective insulin utilization. So you have type 1, where it's just a lack of insulin, and you have type 2, which is the ineffective insulin utilization. Your body doesn't know how to use the insulin. All right, so poorly controlled diabetes can adversely affect pregnancy outcomes. It's challenging sometimes to maintain in pregnancy or manage in pregnancy, and that is why we call on a specialist. Not only will you have your OB/GYN doctor, you will also have your diabetic doctor, and hopefully they're working hand in hand real close together. Diabetes will complicate about 3 to 10% of pregnancies. All right, so type 1, there is a higher incidence of spontaneous abortion and miscarriage with diabetes. The diabetic woman is more likely to experience a cesarean birth, and there's many reasons for that. One is just the fact that oftentimes women with diabetes will have very large babies. They're called macrosomal babies, and they are like 9-pound babies. They're huge, they're beautiful, they're large for gestational age, plump, full face, just those lovely babies. However, they look real healthy, but the thing is, they're not always the healthiest babies. And what is happening is that as the mother is passing over glucose, the higher her glucose level is, it will pass through the placenta. So that baby is getting all that extra glucose, which means the insulin needs go up. So as the baby is producing insulin, that insulin is also acting as a growth hormone, and so the baby is getting very large. Problem with that, well, many problems, but one of the problems with that is insulin also acts as, it can delay fetal lung maturation. So although this baby is getting very big, its lungs are not maturing the way that it needs to. And so sometimes we have to do a quick C-section with that baby. Get them on out. They're too big to have a vaginal birth. It will put them at risk for the shoulder dystocia, which we'll talk about. It can also cause the fetus to be at higher risk for congenital anomalies in stillbirth, especially if that glucose is not under tight control in those first weeks of pregnancies. First 11 weeks of pregnancy, that baby is developing all of its organs, and so if the glucose is not under tight control, it does put them at risk for congenital anomalies. It also puts the mother at higher risk for certain diseases, hypertensive disorders, polyhydramnios, preterm delivery, and of course shoulder dystocia in the infant. Gestational diabetes. Okay, gestational diabetes is diabetes that is formed as a result of the pregnancy. it doesn't mean that that woman is always going to have diabetes after she births the baby. However, it can put her at a higher risk for developing type 2 diabetes after pregnancy. The underlying path, though, is very similar to type 2, and it is insulin resistance. It does have a diabetogenic effect of pregnancy. Okay, the pregnancy is what is causing that diabetic effect. It puts you at greater risk, or the infant at greater risk for macrosomal, which is that very large infant. And for this, we're going to start screening women at 24 to 28 weeks gestation to see if they could be gestational diabetic. And what we'll do with that is a glucose challenge. It's the 1 hour glucose. They take blood beforehand. They make you drink a real sugary drink in 5 minutes. And then an hour later on the dot, they will take your blood and see if your body has excreted all of that sugar, if it's gotten rid of that sugar. If you, however, get a positive that first time, they'll invite you back because they're really nice, and they will do a 3 hour glucose challenge where you have to do the drink again and have your lab tested for every hour on 3 hours. Okay, diabetes mellitus. Okay, so treatment pre-pregnant care, we want her to be getting her glucose under control. We want it a very tight control, 95 to 100. She'll be using insulin therapy, oral hypoglycemic agencies like the metformin, whatever it takes to get it under tight control, diet, therapy, exercise, a mixture of all these things. Fetal surveillance, we will be watching the infant very, very closely. We'll do a fetal echo in the second trimester, the sonograms, non-stress tests, a BPP. If the BPP is non-reactive, we would do a contraction stress test, a CST, as well. And then determining the timing of delivery can be very difficult because, like I said, oftentimes they're macrosomal babies. They're 9-pound babies. However, because of the insulin, sometimes their lungs don't mature as quickly as they need to. So that can be very challenging for the doctor to figure out when is the best time to deliver. Okay, so nursing process for the pregnant woman. Of course, you're going to assess, you're going to see how compliant she is. You are going to watch her glucose and her A1C, and you're looking at all of those, selecting the nursing diagnosis. With that, you're going to set goals, you're going to make them measurable, you're going to make them simple. And anytime we're setting goals, we want a numeric value on there. How can we come back and look at it and say, okay, she accomplished this. It was either yes, the goal was effective, or no, it wasn't. So we have to have some kind of numerical value on there so we can come back and know whether or not she met her goal. Implementation, you're going to be monitoring the management of therapeutic regimen, monitoring for preventing infection, monitoring the fetus status, and estimating fetal weight. Like I said, we're really watching their weight. They can get very large. And then evaluation, goals, and expected outcomes. Of course, our goals, our expected outcomes, healthy mommy, healthy baby. Okay, so watching insulin needs, diet, exercise, whatever it takes to control her glucose needs. Okay, clinical manifestations and diagnosis for cardiovascular disease. Signs and symptoms vary depending on underlying cause of heart disease, and actually you can have a pre-existing cardiac disease can actually be unmasked by pregnancy. You never realized you had a cardiovascular disease, but because of all of the blood volume, the excess, it can sometimes be discovered while you are pregnant. Alright, so the earliest warning sign of cardiac decompensation is persistent rales in the bases of the lungs. And rales are like that bubbling sound whenever you're listening to the lungs. You just hear fluid, you hear bubbling. Treatment activity levels. We're not going to have these people getting up and running a mile or jumping jacks. We're going to try and keep them under control, low stress, diet and medications. We will look at our medications again, determine what category it is. If it's a class A category, that means there's no harm to the fetus. Anything below C, X, we'll be taking her off and moving her to something different. Digoxin is one in which we would not allow the woman to still be on digoxin while pregnant. We would switch her over to something like heparin, which doesn't pass through the placenta. Management during labor and postpartum period. Obviously, we do not want her stressed, and so in the second stage of labor, we are going to tell her not to push. We don't want her vageling down, okay? Pregnancy greatly increases the workload of the heart, and so they have to be real careful with these patients. Okay, nursing care. Excellent nursing assessment and reporting of abnormal findings is critical. They can go bad really quickly, so we're watching them very closely. Most important nursing action is to monitor and teach the woman to recognize signs of cardiac decompensation. And again, rails in the lower bases is typically your first sign that you're going to see. But of course, shortness of breath, turning blue, anything like that as well, feeling dizzy, we want to know about those things. It's especially important for the pregnant woman with heart disease to protect herself from infection. So of course we're going to be teaching her to monitor herself, monitor her temperature. If she feels like she's getting sick, let us know as soon as she feels like she's getting sick. Come in, we'll take care of her in that aspect. Good hand washing, stay away from sick people, okay? And then precautions to avoid clot formation. Every pregnant woman is more at risk for clot formation, but especially someone with cardiovascular disease. So not to sit long, not to cross your legs, which, speaking of which, how many of y'all have your legs crossed too? Getting up, walking, doing those things. If she's traveling in a car, making sure that she's taking rest and stopping frequently. Okay. Periods of the greatest risk, the end of the second trimester. That is when the blood volume has peaked. It's gone up the highest. And then, of course, during labor and early postpartum period, secondary tends to kind of shift fluids. So those are times where we're really watching as well. All right. Advise the woman to get adequate rest and to avoid any kind of strenuous physical activity. Inquire about any kind of illicit drug use or cigarette smoking. Don't you think you need to know if the woman has been doing cocaine or crack or anything like that? And then, of course, cigarette smoking. Those toxins, that nicotine, comes through the blood, and the bloodstream is the baby's only way of its only source for oxygen and nutrients. So it's taking in that nicotine, it's taking in those carcinogenics. So that is why we tell people to stop smoking. It also puts you at greater risk for stillbirth, premature baby, low birth weight, and so we definitely need to know if she's doing any kind of illicit drug use or smoking. We're going to assist the woman with tests for fetal well-being, and that's the contraction stress test. We're going to be telling her to always monitor for fetal kicks, make sure your baby's moving, monitor the woman particularly closely during labor. Like I said, we don't want her actively pushing in that second stage. We don't want that Valsalva maneuver to take place with her and for her to vagal down. Do not encourage active pushing during the second stage of labor. Just said that. Postpartum period, immediately report fever, increased bleeding, and any signs of decompensation. Obviously, these are the women that we're not going to give her a big bolus. Even if she wants an epidural, we're not going to push fluids on them. We're not going to give the fluids quickly. We're going to give them slowly. Avoid any kind of rapid infusion. And then signs of decompensation, of course, you're watching her blood pressure, you're watching her heart rate, you're making sure she isn't turning blue. Okay. All right. Anemia. Iron deficiency anemia, clinical manifestations and diagnosis. Common signs and symptoms of iron deficiency anemia in a pregnant woman include tachycardia, tachypnea, dyspnea, pale skin, low blood pressure, heart murmur, headache, fatigue, weakness, dizziness, and pica. That is the ingestion of non-food substances such as clay or laundry starch or just anything real weird like that. They have an iron deficiency if they're doing those things. Or pagophagia, which is frequent chewing or sucking on of ice. So if someone is just cup after huge cup of ice just going at it, they may have an anemia problem as well. Okay, so we define anemia as the hemoglobin is less than 10 grams, okay, during pregnancy. For treatment, oftentimes we will not give them a blood transfusion. We'll try and treat it with diet instead, so know what has iron and what they should eat and encourage them to eat those things. Okay. This is not matching mine for some reason. Okay. Nursing care with iron deficiency anemia. Counseling. Vitamin C enhances iron absorption. This is a question that NCLEX loves to give. They want to know and make sure that you know that you don't give milk with iron. You give something like vitamin C. So if I am the patient, rather than you're giving me my iron pill, you're going to offer me some orange juice rather than milk. That's a huge one, but I promise you, every question is going to say, give it with milk. No, you give it with orange juice, vitamin C. Okay, iron supplements, they can predispose you to constipation, so make sure they are drinking a lot of water, taking a stool softener if they need. And then sickle cell anemia, support and teaching. With sickle cell anemia, and that is actually the page I'm looking for. There it is. Okay. Sickle cell anemia, clinical manifestations and diagnosis. Sickle cell anemia is when the hemoglobin molecule is shaped like an S, and because it's shaped like that, it clumps together. And when they clump together, it causes ischemia. The blood can't get through. It's all clumped right there together, and so there isn't any blood flow down below that. It can cause ischemia, which will cause death, basically. And so what we're going to do for these patients is we're going to hydrate them. We're going to give them lots and lots of water. We're going to tell them to rest. They need to avoid stress. Stress triggers crises. So we want them to avoid anything that's causing them stress and to know what kind of triggers their crisis. Okay? Oftentimes they can experience recurrent bouts of pain in the joints, bones, chest, and abdomen. For treatment, again, we're going to try and get them to rest. We're going to give them lots and lots of fluid. Hydration is best. And then we're going to encourage them to eat a balanced diet. If, however, we needed to treat them with medication, there is a medication, it's called Hydrea, and it can decrease the frequency and the severity of crisis. However, tetragenic to the fetus, or it is at least in animals tetragenic. So we don't really recommend giving that. So instead, adequate rest, avoid stress, and lots of fluid. Okay. Asthma. Alright, let's talk about asthma. Asthma is the chronic inflammatory disease of the airways. In management of an acute exacerbation, we are going to try and prevent any kind of triggers. Oftentimes with asthma, it's something triggered that. So we need to figure out what triggers it, whether it's cat, dust, trying to figure out and know what that trigger is, and of course avoiding it. Labor and birth management. We still want these patients to have a vaginal birth if they're able to. We just know that we have to plan in advance for it. Oftentimes the patient may fear the stress of labor is going to exacerbate her asthma symptoms. Typically this is not the case. We will treat her with fentanyl. because fentanyl does not cause histamine release, or she can have an epidural. Again, they want to have a vaginal delivery as long as the woman can tolerate it. If she were to have to do surgery, epidural or spinal anesthesia is the preferred method over general anesthesia. If general is required, then the anesthesiologist will order atropine to induce bronchodilation. Typically, like I said, she doesn't have as many problems as you would think, but there is the fear of that, so it's talking her through that as well. Epilepsy. Epilepsy is seizures. Okay, so clinical manifestation. The treatment. Current recommendations are for the woman to remain on the drug that is most effectively controlling her seizures. However, if it is tetragenic to the fetus, we have to weigh that out, and the doctors will go into great details with that. What they'll try and do is wean her off of that drug and get her to the lowest amount of drug that she can be on that is still effective for her, that will not cause her to have a seizure. Oftentimes there's a lot of planning in advance for a woman who has epilepsy to have a baby. They want her to wait 6 months after any seizures to make sure that they're under control. In the U.S., over 20,000 women give birth with epilepsy, of course, and a vast majority of those babies come out completely healthy. So even though the epilepsy drugs have very bad rep, a lot of times they're able to have really good prognoses with these clients. What else? Okay, nursing care. Teaching the importance of carefully following her treatment regimen, not getting off her seizure medications completely, because having a seizure while you're pregnant wouldn't be good either. Teaching her the importance of eating a diet high in folic acid and taking folic acid supplements. Of course, we're going to push the prenatals, but also taking any kind of folic acid in additionally is going to help. What does folic acid do? Neural tube defects, right? We're going to provide emotional support for her during the prenatal testing for fetal anomalies. Again, tetragenic can cause the babies some harm, so sometimes that can be very nerve-wracking for those moms, and they'll have guilt, and we have to be there and be supportive for her in that. All right, infectious diseases. Prevention is the best treatment. Okay. With torch diseases, often there is actually medications they can take. However, the medication that is best for mom is not typically best for the baby. So these are some of the infectious disease. Toxoplasmosis and other infections. You'll see torch, acronym, toxoplasmosis. Other infections, which include hepatitis B, syphilis, varicella, herpes zoster, rubella, cytomegalovirus, and herpes simplex virus. Okay, so prevention is the focus of these interventions because many of the torch interventions do not have effective treatment regimens. So we want to get a hold of these women before any kind of infectious diseases come along. And how do we do that? We teach them not to have multiple sex partners, to use protection, things like that. Routine screenings for hepatitis B, syphilis, and rubella. Torch screen. Now, this torch screen can be ordered by the doctor, and it's usually not ordered on everyone, but if that woman has risky behavior, multiple sex partners, then they'll go ahead and order that for her. A late or an old infection, latent infection, is that the first titer shows up positive, but then she comes back and she has a second titer and it's negative. So it's just saying that it's an old infection. It's not current. It's not raging at this time, and that more than likely it will not hurt the baby, cause any harm to the baby. Okay. Sexually transmitted infections. Many STIs are reportable diseases tracked by the CDC. Chlamydia is the most common STD in the United States, and untreated chlamydia increases the risk of contracting HIV or AIDS. Gonorrhea is second in prevalence, resistant to antibiotics, and can leave the woman infertile or susceptible to ectopic pregnancy because of the scarring in the reproductive tract. Okay, so they're very serious, and we want to make sure that they're treated early and that they don't even occur if we can get to them in time. All right. With this, you will also notice pelvic inflammatory disease that goes along with that, and of course can cause the scarring in the reproductive tract. Okay, you can give antibiotics, however sometimes they are resistant, and again it goes back to what's best for the mom is not always best for the baby. But if she does have a raging infection, usually we will go ahead and treat it. Okay, human papillomavirus. All right, most common viral STI in the United States. It does have a tendency to increase in size during pregnancy, so it will flare up. Neonatal HPV infection can result in a life-threatening laryngeal papillomas, which is basically tumors on their laryngeal. With human papillomavirus, there is now a treatment for it. It's Gardasil, and they are wanting to mandate where all women who are 9 to 26 get the injection. It's 3 injections over 6 months and before adolescent years. It can prevent cervical cancer as well. And I think they're actually not mandating, but they're having it where men can get this injection as well. Okay, trichomoniasis is associated with adverse pregnancy outcomes, often premature babies, rupture of membranes prematurely, and low birth weight. It can be treated with flagyl. HIV and AIDS, it's very important for the practitioner to know the pregnant woman's HIV status. If she is positive and has an infection at that time, we will not have that mother have a vaginal delivery. We'll go ahead and do a elective C-section. HIV babies are not to be breastfed, and you're to wear gloves with them the entire time. Alright. Therapy is for some pregnant women. The therapy is the same for pregnant women as it is for non-pregnant women. It's the antiretroviral medications. Like I said, we will schedule a C-section. It gives that baby less than 1% chance of catching HIV, as where a vaginal delivery will give them a 25 to 35% chance of becoming infected. The 2 main goals of treatment for the pregnant woman infected with HIV is to prevent progression of the disease in the woman and prevent the transmission of the virus to the fetus. We are going to ensure confidentiality. We're not going to go spreading around that she has HIV. You have to be very professional in that. If the woman is HIV positive, ensure she understands the risk to her as well as her sex partners and to the baby. Explain the risk of the transmission of HIV and the benefits of therapy. Explain to her that she does not need to breastfeed, and then explore her understanding of the treatment regimen. Is she already on the antiretroviral medications? Is she taking it, and is she taking it consistently? The protocol for that is sometimes can be very complicated. It just has to be at a certain time. Alright. Nursing process for the woman with an STI implementation. We're going to control the risk of the STIs. We're going to maintain immune status and protection from additional infections, ensure knowledge of STIs and treatment regimen, make sure that she is taking those treatments as she is supposed to, as it is directed, enhancing self-esteem, reducing anxiety, making sure that she knows that though there is a risk of transmitting these diseases to the babies, there's also a good chance that we can prevent that if we do these things correctly. Evaluation of goals and expected outcomes. Okay, pregnancy complicated by intimate partner violence. All right. The cycle of violence. You have the tension building phase where things are just starting to get bad and you can tell it's building. You have the explosion phase where everything hits the fan. You have the absence of tension, and then you have the honeymoon phase, and then it starts all over. Building back tension, explosion, absence of tension, honeymoon phase. Okay, so there are many warning signs. The goal of the abuser is to exert and maintain power and control. Treatment, oftentimes, we cannot pull these women out of the homes as much as we want to. It has to be their decision. We're going to do routine screening on all the women. It's the key to assisting those who are ready to report abuse and receive help. So we have to be real careful and look for signs that there may be abuse. Interventions for the victim of the IPV are directed towards safety assessment and planning. How can we get her out? Nursing care assists the RN to assess for abuse, determine whether a woman should leave an abusive relationship. Has to be made exclusively by the woman. We cannot make that decision for her. Always document the woman's responses to questions about intimate partner violence and document it completely. Whatever she says, you write it down, put it in quotes. Be careful to respond with supportive statements. Document your assessment objectively. Be knowledgeable about local resources. Where can we send her to get help? Okay, oftentimes men can be victims too. However, women are usually the ones who actually report it. Okay. Adolescent pregnancy, clinical manifestations. Many pregnant teens seek late prenatal help. They don't want to really tell anybody. They're fearful of disclosing their pregnancy, so they don't get help early on in those early stages. The best treatment for a teenage pregnancy is prevention. Talk to her early about sex. Let her know that there are options for birth control and find a birth control that is going to work best for her. Advocacy for the pregnant adolescent. We have to support her. We have to support whatever decision she makes, whether it's to keep the baby, to give it up for adoption. We're going to help the teen to develop an adequate support network. Who can be there for her? Who is going to be her support? Is it her mom? Is it her neighbor? Is it a teacher at school? Whoever that is, helping her to develop that support team. The nursing care, we're going to care for her developmental needs. Even though she is pregnant, it does not change the fact that she still has developmental tasks that she has to accomplish. At this stage, she is in identity versus role confusion. And so all of a sudden, becoming a mom can really wreck that role confusion, that identity state. And so it's helping her walk through those things and figure out who she is. We have to care for her physical needs. Adequate nutrition is essential. All of the nutrition that she is taking in is still going to help her grow. And now she has a baby, and so the nutrition that is still trying to help her grow has to be divided for her and the baby. So that can be kind of complicated. Not to mention, a lot of times adolescents don't have the healthiest diet. I can remember when I was a teen, it was Nutter bars and orange juice. You know, yay, at least I'm getting my orange juice in. Who am I kidding? Things haven't changed yet. I'm still that way. Okay. Caring for emotional and physiological needs, you've got to be knowledgeable about community resources for the pregnant teen. Where can she go? Are there other pregnant teens in the neighborhood that she can talk to and have support from? All right. And then pregnancy for later in life, concerns about pregnancy later in life. A woman who is over 35 years old is at higher risk. And oftentimes they know this. For whatever reason, they put off having a child until later, and it could have been that they couldn't get pregnant, and so now they're finally able to get pregnant. So a lot of times we give them all this information, but sometimes they're a little overwhelmed, and they know that they're at higher risk, but we don't have to tell them all the details. Sometimes we have to back off and tell them exactly how much they want. Okay. Women at risk who are over 35 are at higher risk for conceiving a child with chromosomal abnormalities, spontaneous abortion, miscarriage, preeclampsia, eclampsia, gestational diabetes mellitus, preterm delivery, bleeding placental abnormalities, and they're twice at the risk of someone who is much younger than them. So knowing all these things, it's a huge list, and sometimes it's just too much to hear. Let them know the concerns, let them know that there is a higher risk, but at the same time, be supportive and be there for them, okay, and approach them with an open mind. All right, that takes care of everything to